Now we're going to see the primary amenorrhea. Primary amenorrhea is defined as the absence of menses on a patient that is, let's say, 15 or 16 years old with secondary sexual characteristics, or the absence of the secondary sexual characteristics in a 13-year-old patient working out a woman, so a clinical woman. So the test certainly will include the BHCG, just to rule out pregnancy. Always we need to rule out pregnancy. Prolactin, because if we have increase in prolactin, this decreases the release of FSH and LH, so the patient will have the decreased estrogens and what that comes after that. So prolactin, TSH, remember that the TRH also influence on the prolactin levels, and this will influence on the FSH and LH. Then we also need a pelvic speculum. So let's divide these conditions in 3 categories. When there is uterus present and breast present. So first, the rules. If we see breast, this means that the levels of estrogens are good. If we see pubic or axillary hair, means that the androgen levels and the receptors of androgen are normal. Alright, so now you will have uterus present and breast present. Usually would be now the primary amenorrhea in a patient, for example, with anorexia nervosa, and this now the patient would have, for example, just a low body mass index, etc. So malnutrition. On the other side, if the patient has good food intake, etc., is usually a anatomical cause, so like vaginal agenesis or imperforated vaginal septum. So the triad for uterus present, breast present, primary amenorrhea would be primary amenorrhea, the uterus present and breast present, and third, depending on which one we're talking about. If it's anorexia, it would be decreased food intake or malnutrition. If we're talking about the vaginal agenesia or the imperforated septum, it would be the triad of primary amenorrhea, uterus present, breast present, and good nutrition. For the anatomical causes, we would look them with a pelvic speculum, and the treatment is surgical. Now, the next condition is uterus present, absent breast, so no breast. So here the no breast is because there is decrease in estrogen levels. So this would be certainly a 46XX woman because it has uterus, but the problem is we have no estrogen. So this could be the gonadal agenesia. The most common cause would be Kallmann syndrome, or Turner syndrome is gonadal agenesia, Turner syndrome, and the other is the hypogonadotrophic hypogonadism. Here the most common cause is Kallmann syndrome. So in Kallmann syndrome there is an abnormal migration of the cells in the hypothalamus that secretes the GnRH. So there will be decrease in the FSH and LH. So there will be no estrogen. So the ovaries are not being stimulated, even though the patient has ovaries. The patient usually has anosmia because there's also lack development of the olfactory system due to the failure in migration of the neurons. There could be midline defects like cleft palate or cleft lip. Also, the patient could have unilateral renal akinesia or syndactyly or auditory deficiency. The pubic hair and the axillary hair in the woman is usually normal because these patients have androgen from the adrenal glands. Alright. The treatment would be estrogen plus progesterone. The estrogen is to develop the secondary sexual characteristics, and the progesterone is because remember that when we have unopposed estrogen, the patient could have endometrial hyperplasia and then endometrial cancer. So the unopposed estrogens are risk factors for cancer, so we always need to give progesterone. Plus the human menopause gonadotropin, that is the analog of the FSH. Now, in Turner syndrome, the patient has the karyotype is 46XO. So this could be mosaicism, in which the patient would have some of the cells being 46X0. Mosaicism is 45X0 and 46XX mosaicism. And not mosaicism would be the more severe form, in which all the cells would have 45X0. Here the patient will present with a webbed neck. This is due to the cystic hygroma collapse. Also, the patient would have aortic valve, bicuspid aortic valve, that leads to early stenosis of the aortic valve, pulmonary artery hypertension, aorta coarctation, etc. These patients have strict ovaries. The problem with the sexual characteristics are due to the deficiency of the long arm of the X chromosome and the short stature. Short stature is to the deficiency of the short chromosome of the X chromosome. Now, these patients theoretically can get pregnant because they have uterus, but they don't have any mature follicle, so they need an egg donor. So genetically the child would be from other woman, but the one who will carry the pregnancy would be this woman. Or maybe we can take the DNA of some cell of this patient and try to fertilize them with sperm and then put it again on this patient so that she can carry the pregnancy. Next, the triad for Kallmann syndrome was the primary amenorrhea plus uterus, yes, breast, no, plus anosmia. And the FSH would be low. In Turner syndrome or gonadal agenesia, here, gonadal agenesia, the patient has the triad of primary amenorrhea, breast, no, uterus, yes. Breast, no, because the ovaries are not producing the estrogen, so there will be no secondary sexual characteristics. And the FSH would be high because there is no feedback inhibition. Now the last case is when we have the uterus absent and breast present. So here we have the Mullerian agenesia and the testicular the androgen sensitivity syndrome. Androgen sensitivity syndrome. So here the patient with Mullerian agenesia. Remember the results of Mullerian duct or paramesonephric duct. This includes the uterus, cervix, proximal vagina, and fallopian tubes. So if we have Mullerian agenesis, then we will not see any one of these primary internal organs. So the patient will have no uterus, but the ovaries are normal. So the patient will have estrogen production. Estrogen production that will lead to the secondary sexual characteristics. So for that, the patient has breast, but has no uterus. Next, these patients usually also can have some renal problem, and if they want to get a child, they could, but they need a in vitro fertilization surrogate. That is, the genetic material would be from these cells, but to carry up the pregnancy, this patient could not do it because it has no uterus, so it could be done by other women. So the trial for Mullerian agenesia is primary amenorrhea plus the secondary sexual development. That this includes the breast and the pubic and axillary hair. So you have breast, yes, and uterus, no, and the pubic and axillary hair. Because the pubic and axillary hair is the difference clinically between Mullerian agenesia and the androgen sensitivity syndrome. Because in androgen sensitivity syndrome, the patient has, actually it is a 46XY, so this is a genetically, chromosomically male, but because there is no response or no sensitivity of the androgen receptors, the androgen, the testosterone, the dihydrotestosterone have no impact on the tissue. So testosterone that aids on the internal genitalia of the male, that is the ejaculatory duct, deferens duct, seminal vesicle, and epididymis, they would be absent because the testosterone cannot bind to the receptor. So, but also because this is a 46XY, the patient produces the Mullerian inhibitory factor that inhibits the development of the paramesonephric ducts of the Mullerian ducts. So the patient will also have not the woman internal genitalia. So the patient has no internal genitalia, and on the external genitalia, remember that the dihydrotestosterone produces the male external genitalia, that is the prostate, penis, and scrotum. But because the receptors are abnormal, there is no response to the dihydrotestosterone, and so will be unopposed estrogens. So the patient will develop the external genitalia of the female, the distal vagina and the labia majora. Because there is abnormality in the androgen receptors, the pubic and the axillary hair would be absent. Remember that pubic and axillary hair means that the androgen levels and the androgen receptors are normal. Here would be abnormal. So the triad for androgen insensitivity syndrome is primary amenorrhea, uterus, no, breast, yes, because of the unopposed estrogens, and decreased pubic and axillary hair. So they actually look like women. They come for primary amenorrhea, and we see that they actually they have a karyotype of 46XY. So if we have a uterus present and a breast absence, we have either Turner syndrome or hypogonadotrophic hypogonadism. So for this we will ask for the karyotype, and for the uterus absent and breast present, we could ask for other tests to see the Mullerian agenesia or the karyotype of this genetically male that looks like a female. We have other disorders of the sexual category that include the 5-alpha reductase enzyme deficiency. This is the one that converts estrogen to androgen. Estrogen to androgens. Sorry, androgens to estrogens. Sorry, androgens. Androgen to the androgen. And testosterone to dihydrotestosterone. So the patient has internal genitalia. This is 46XY. Has internal genitalia because the testosterone is there. The receptors are normal, but there will be no external genitalia because the dihydrotestosterone is absent. So the patient will have a female external genitalia, but a male internal genitalia. If the deficiency is not complete, the patient will have the ambiguous genitalia. There are some other disorders like super female 47XXX, super male 47XYY, or things like that. The hermaphrodite is when the patient has testes and ovaries. The male pseudohermaphrodite is when the patient has male internal genitalia and female or ambiguous external genitalia, like in the 5-alpha reductase enzyme deficiency.